what are the options for a painful stiff knee? Do we have to live with it? Do we fuse it? Do we arthrodese it? Or there is any way in which you can relieve the pain also and get movement also? Hello, I'm Dr. Rohit Lamba. I'm a consultant orthopedic and joint replacement surgeon from Gurgaon, India. Let's talk about the case of the week, which is a 32-year-old gentleman. He's an ex-army man. He's actually currently serving but not able to work because of his knee problem. So what happened to him was around 1.5 or 2 years ago, he had a gunshot injury to his knee, because of which he sustained a fracture of the thigh bone, which is called femur, at the very lower end, in which it forms the knee. It was managed there in his home country in Somalia by surgery. They first put a wire across it, and then after a few days they plate it to fix it. But in all these surgeries, the bone unfortunately did not unite in the right position. It also developed some infection. The plate was removed, and all because of all of these surgeries, he developed a total complete stiffness of his knee. So his knee is stiff in straight position. It does not bend. It does not move more than 5 to 10 degrees. So, and on top of it, he also has pain. He is not able to walk with any support. He has to use 2 crutches to stand and walk. Has a lot of pain and misery. So he came to us and we diagnosed everything, did all the investigations, special CT scans to find out that the bone around the lower end of the thigh bone was damaged and it was misshapen, causing arthritis. Now, along with that, there was also a focal area of some infection there. So we advised him, counseled him to clear out the infection first, in which case, for the first time, we took him up for surgery, cleared out that red bone and infection area and put some bone graft in it along with some antibiotics. So that cleared up his infection, healed up the defect in the bone and made him up fit for a knee replacement. Because with the kind of arthritis he had, the only hope for him was a total knee replacement. Now, this is not a normal surgery. First, with the exposure, the knee, you have to open up the knee. When you open up the knee for a knee replacement, you have to bend it. In this case, it was not bending at all. So what we have to do essentially in this case is, we have to expose the knee so this is the kneecap, and this is the patella tendon, and this is the quadriceps. So this is the insertion in the leg bone of this patella tendon. We have to essentially, with a piece of bone, we have to take it away, remove it, and put it on the side so that we can get a proper exposure of the knee and we can bend it to perform this surgery. So we did an osteotomy to get a better exposure. Now, for doing this surgery, you don't have normal landmarks of the bone for us to use normal instruments during the surgery. So we had to use a special computer navigation system to get a proper alignment of his leg from the hip down to the ankle, to see what is the deformity, how bad it is, in which plane it is deformed, and accordingly make the bone cuts to put the implant in the right position. So the computer navigation system provides us the direct live picture of the knee with all the deformities and tells us where to cut the bone, in which position, and where to place the implant so as to get the best outcome. So along with that, we use some special implants as well. In these cases, because you're doing an osteotomy at the lower end and the femur bone, thigh bone, that also is deformed. So we have to use special stemmed prostheses in both the femur and the tibia. So we had to use extra rod extensions going up into the femur and into the leg bone, which is the tibia. That gives us extra stability and allows us confidence to allow the patient to walk full weight bearing from the next day onwards. So this was the plan. Everything was executed nicely on the table. 6 weeks after the first surgery, we took him up for surgery after having made sure that there is no evidence of infection, the ESR and CRP are normal, and the wound is nicely healed. We executed the plan according to what we had planned. The exposure required osteotomy. We got inside, used the computer navigation system to mark out the bony landmarks and to make the bone cuts, and then put the special prostheses inside. Now, after this surgery, he required special anesthesia in form of epidural anesthesia, so that he can start mobilizing the knee on a special machine called CPM, continuous passive mobilization. So this was started right next day after the surgery, by which the knee, which was not even bending 5 to 10 degrees, after 4 to 6 weeks of vigorous physiotherapy has come to almost 90 degrees of bending. So this is the outcome of the patient. This is how he's walking after the surgery, and is very happy with the fact that he's not having any pain. He's not requiring to use any support for walking in form of stick or walk or anything, and he can bend his knee to sit on a chair comfortably. So we hope to continue exercises with the CPM machine so that he can further improve his range of motion. And as we keep on improving, we'll post his further recovery as well. Thank you so much for the patient listening, and keep subscribing to our channel. Keep coming back to our channel for more such patient stories and more such happy outcomes. Thank you.